Living longer, living healthier, living better than ever before. Welcome to Mountain Pacific's Healthy Living for Life, a weekly series that gives you the information, education, and expert insight you need to become an active participant in today's ever-changing healthcare climate. Here now is today's program host.
You have cancer. 3 simple words with a huge impact. They can change the way you see life, how you live life, and perhaps even give you a new appreciation for life. So what's it like to live with cancer? What's it like to live with someone who has cancer? How is it diagnosed and treated? Are there resources available? Your answers here on Healthy Living for Life. I'm Janet Whitmoyer, your host. Stay tuned. Chelsea Rice joins us, who at the age of 35 was diagnosed with a rare form of bladder cancer. Thank you so much, Chelsea, for being with us and sharing your story.
Thanks for having me.
Absolutely. So the first thing is, can you tell us about how you knew something was wrong?
Well, in early 2012, I started having UTI-like symptoms. So some bloating and some burning. And then shortly thereafter, I started seeing some drops of blood in the toilet. Oh. And I thought it was spotting, but it ended up that it was bleeding coming from my urethra.
Oh, gosh.
And it went on and on. I went to several doctor visits to try and address it through antibiotics. And it was in June when I finally thought, okay, this is worse than I thought it was.
So at that time, you did seek out assistance to get it diagnosed. What tests did you undergo to come up with the diagnosis?
I actually didn't have insurance at the time, and so I had to wait an additional 4 months to see somebody. I had a CT in October of that year, and my insurance finally kicked in, and that's when we learned that I had a tumor on my bladder. Immediately afterwards, I had a biopsy which revealed that it was squamous cell carcinoma of the bladder, a rare and aggressive and potentially fatal bladder cancer.
So when you were diagnosed, what were your treatment options and how did you choose which option that you were going to take to treat the cancer?
So I went back to Rochester to visit with a urologist at Mayo Clinic, and because there's no studies done on this particular kind of cancer, they based my treatment on the most aggressive treatment they would give for transitional cell carcinoma of the bladder, the other more common form of bladder cancer. And it was determined that I would do 12 rounds of chemo, that's approximately 4 months, and then undergo an 8-hour open surgery called a radical cystectomy. And
wow, that's a lot of treatment. How did you decide to go down that path?
You know, I didn't feel like I had options.
Okay.
I felt like I really had, the option that I had to go with was to submit to what this regimen that was decided for me was. I had considered, eating healthier or not undergoing chemotherapy at all. But all in all, my research found that chemotherapy was one of the better forms of treatment in order for longer survival.
Okay. You mentioned earlier that you didn't have health insurance when you figured this out, and obviously this was quite an expensive adventure that you were on. What did you do, or what did you have to go through to get the bills paid for this type of treatment?
You know, as soon as I was denied insurance for the urinalysis that I took in February of that year to determine if I had an infection or not. I kept my appeals in the air with my insurance company the entire time I went through chemotherapy, which was really, really hard. My family and friends back in Portland fundraised about $10,000 for me by throwing a big party. And my friends and family and community here in Helena raised an additional $40,000 so that I was able to at least put a down payment on my surgery if I needed to. Otherwise, we never had insurance, and so I applied for charity care through my hospitals.
And doing all of this while you're undergoing the treatment for the cancer.
Yep, and my caregiver was working full-time to make sure that we could at least get our basic needs met at home.
And speaking of caregivers, that's a really important point because we know cancer is very emotional for the person that's going through it, but it can also be a really difficult time for the folks that are taking care of those. And you do have a caregiver, but we know that that wasn't always easy for her as well. So can you share with us a little bit about the journey that she went through during your cancer treatment?
You know, my partner of 10 years was remarkable. She didn't cry, she never got angry or frustrated with me. Somehow she just sucked it all up and remained strong, and I called her my rock. And that was wonderful and helped me to really do better to survive. When we learned that I would survive, though, she had been compartmentalizing all this emotion around the fact that she really didn't think that I was going to make it. And at the end of that, she plummeted into a really deep depression as a result of trying to contain all that emotion. And so it was difficult for us on the back end, even though we survived. And we still continue to go through sometimes difficult things as a result of the impact, the emotional impact in particular of cancer treatment, and, you know, reworking your life on the other end of it as a survivor.
So you've come a long way in the journey. Would you say, have they told you your cancer is cured?
Nope, it's just no evidence of disease.
Okay, so with that resolution, what is your health like today?
You know, it's really good considering what I went through. I do have lymphedema from my navel down to my toes, which is a side effect of treatment, and it's a costly side effect. And I have to wear compression garments every day of my life, and I deal with swelling depending on my activity. And so, you know, my health is good. I'm really fortunate to have the strength that I do and the cognitive abilities that I still do.
And so now you have the support, though, with your caregiver, and also you have insurance.
I do.
Is that
Yes.
correct? So that's really good. So I also want to ask you a little bit about your work with the American Cancer Society.
Yeah.
What does that work mean to you in light of what you've gone through with your cancer diagnosis and treatment?
So I work for the Cancer Action Network, which is aligned with the American Cancer Society and is the nonprofit legislative lobbying arm of the American Cancer Society. And so my experience with cancer gives me the passion to do the work that I do at the state capitol and at the federal level to advocate for cancer patients and their families, because we often, as patients, cannot go and advocate for ourselves because we have far too much to take care of.
Oh, awesome. Well, thank you so much, Chelsea, for sharing your story with us. My next guest comes from St. Peter's Oncology Services. We'll be right back after the break. Please welcome my next guest, Melissa Cobb. Thanks for being with us, Melissa.
You bet, yeah.
Can you tell us a little bit about your role as a nurse practitioner in the oncology department at St. Peter's?
Sure, yeah. So I work with a team of specialists and professionals at St. Peter's Hospital that includes an oncologist and oncology RNs, and we collectively manage patients with cancer. In my role specifically, do mostly symptom management, so symptoms of cancer and of treatment. That includes things like pain or nausea, vomiting, obstruction, and those kinds of things.
Great. We hear a lot of people talk about cancer, but can you tell us really what is cancer?
Sure. So cancer is basically changes in the DNA of a cell that sort of makes the cell not function like it normally would, not like a healthy cell, and then also takes away the regulation of replication, so allows the cell to grow out of control and sort of invade other tissues and distant organs, and it's sort of non-functioning and out of control.
So how do you find or diagnose cancer?
So cancer is found in a number of ways. Sometimes it's found on screening. Sometimes patients present with symptoms. Typically, or oftentimes, it's found on imaging studies, such as like a mammogram. An example of a screening would be like a colonoscopy or a PAP. Okay. And patients then go on to probably more diagnostic studies like CT scans, ultrasounds, those kinds of things, but ultimate diagnosis is based on tissue biopsy that's sent to a pathologist and looked at in a lab.
Okay, so once the cancer has been diagnosed, what happens next for a patient?
Usually the ordering provider receives the tissue pathology, and then appropriate professionals are contacted for consultation, such as an oncologist or a surgeon, and then they would sort of meet as a team with a patient.
Okay, so once you've met with the specialist, do they decide then how the cancer is treated? What's the next step after that?
So treatment is based on staging and type, and there's 3 main modalities of cancer treatment. Generally, there's either local therapy, such as surgery or radiation, and then systemic therapy that includes like immune therapy, biotherapy, hormone therapy, traditional chemotherapy. And here in Helena particularly, and all over the country, it's based on national guidelines. That's the standard of care. And so your physician and your team will work with you on making those options available.
Okay. You brought up immunotherapy, and we hear a lot about targeted and immunotherapy. Can you tell us the difference between those 2 different types of therapy?
So immunotherapy basically helps your body's own immune system to fight the cancer. It sort of beefs it up a little bit. And targeted therapy works on specifically targeting different modulators on the outside of tumor cells. So instead of having a more systemic infusion or something like that with chemo, a targeted therapy goes right to, or tries to go right to, the cancer cells.
With so many different types of treatment out there, how do you decide really what is the best way to treat a person's cancer?
So again, it's based on national guidelines. When a patient receives a diagnosis and they're staging, we look on NCCN national guidelines and sort of go based on that and try to work with the patient what their goals are, and develop those realistic goals for them, whether it's curative or palliative. And really the patient is involved in the whole process.
Okay, so they get to have some say
Absolutely.
in the treatment.
Absolutely.
So the NCCN guidelines, is that what you said?
NCCN. Yeah.
NCCN. So would that mean that a person that was treated in Montana would be under the same guidelines as somebody in New York?
Right, that's the standard of care, yes.
Okay, so we can feel rest assured that patients in Montana are getting great care for their treatment.
Absolutely.
Awesome. So another question a lot of people have is, can cancer be prevented?
So when I think of cancer prevention, I think of screening and vaccination, and I also think of risk reduction. So risk reduction includes things that are like associated with cancer. We talk about obesity, so physical activity and a healthy diet are ways of reducing your risk of cancer. We talk about decreasing your tobacco use or eliminating tobacco use because that's a carcinogen, limiting alcohol use, and avoiding UVA and UVB rays, the sunlight or tanning beds, things like that. As far as prevention goes, you can work with your primary care provider to figure out appropriate screenings that are good for like a person's age group and their other risk factors. And then there's vaccination against viruses that are oncogenic.
Oh, awesome. So you seem to have a very wonderful passion about cancer treatment. I'm just curious to know, how did you get involved in oncology nursing and actually as a nurse practitioner?
When I graduated from Carroll, my first job was at St. Peter's Hospital. I started out in pediatrics, and the floor was combined, pediatrics, oncology, and surgery. And I just sort of fell into oncology. And when I met with the patients and the providers, the great people that we have there, it sort of felt like a good fit for me. So I worked in oncology as an RN for 10 years there, and then went back to school for my master's degree 2 years ago.
And then just came back to be a nurse practitioner right where you left off.
Right.
Oh, that's awesome. Well, I'd like to thank you, Melissa, for sharing all sorts of great information with us on cancer. Up next, we'll meet someone who helps patients with their caregivers navigate the healthcare system from diagnosis through treatment. Stay with us. Emily Burton is an oncology nurse navigator with St. Peter's Hospital. Welcome to Healthy Living for Life, and thanks for being with us,
Thanks for
Emily.
having me.
So can you tell me what a nurse navigator is?
Sure. It can mean a very variety of different things to people across the nation. Here in Montana, especially at St. Peter's, what we do is advocate for our patients. We're with them from the beginning of their diagnosis all the way through treatment and into their survivorship. So it can be different at different hospitals, but that's how our model of navigation works here.
So if patients run into barriers with their treatment, do you help them through that? And can you tell us a little bit about what you do to actually ease that burden for them?
Absolutely. So when patient is diagnosed, you got to think about we're getting diagnosed younger. So these are a lot of the working people. They have families, kids in school. So all of those can become barriers. We're in a rural community, so we have people that come, from far away that need treatment. So transportation, lodging, work issues, finding transportation and daycare for their kids can be an issue for patients too. And what we do as navigators is work to decrease those barriers, provide them resources to help them be able to get their care in a timely manner without having as much stress. So we try to help them with resources.
Oh, that's great. And you mentioned lodging, and that, especially for the rural folks that are coming in and may need hotels. We hear of some organizations that partner with folks to provide lodging. Is that something that you actually work with in Helena to help folks coming from outlying areas to get their lodging?
It is. We have people that come from White Sulphur Springs, Dillon, lots of different places, and we work with the American Cancer Society. They have a program that helps partner with hotels in the local communities to provide lodging for patients that are coming from out of town. A lot of other hospitals in Montana and throughout the nation though as well, their navigators work with their hospital. They might have a house or apartments or something that the patients can stay at too. So that's all part of a navigator's job.
Great. So when a patient gets referred, how do they get actually in touch with a nurse navigator? Can you walk us through the process of how you actually meet patients and how that process works?
Yeah. So at St. Peter's, we have two different nurse navigators. We have Pam Sasser, who's our breast and gynecological nurse navigator, and then myself, and I do the remainder of the cancers. Pam gets involved a lot earlier with our breast patients because as soon as there's an abnormal mammogram that requires a biopsy, she's called in. And then she sits with the patient and she does the education about what to expect with the biopsy. Quite often she goes in with them for their biopsy and is able to provide support through that. And then she attends appointments with them for their various specialists to get the cancer worked up. Okay. Then with me, just with the nature of how other cancers arise, they may be found on an ER visit or just a regular screening through their primary care. I tend to get involved a little bit later, usually when they're scheduled with a specialist when something abnormal is found. So when they see a surgeon or our oncologist, then that prompts a referral to me.
Okay, so for the folks that may not be from Helena, would they look to their physician, the specialist, to ask if there's a nurse navigator so that they would have access to your type of services?
Absolutely, and some of our out-of-town folks find us through our specialists if they have a primary care in a more rural area and they're referred into a specialist in Helena. I work very closely with, say, the surgeons and the oncologist and the radiation oncologist here, so anytime they get a referral, then they'll be in touch with me too.
So you're with these patients pretty much throughout their treatment at various stages to help them with the needs.
Correct.
What happens when they've completed their therapy? Are you still there for them, and what kind of services do you provide?
Absolutely. This is one of the more exciting growing areas in our field right now. The Institute of Medicine put out a paper called From Cancer Patient to Cancer Survivor, Lost in Transition. And that really spurred the oncology community throughout the nation to do better for our patients. We're curing more patients at a younger age, and then they're living with these side effects from their cancer treatment. And how do we do better as oncology professionals to make that transition easier for them, to improve their quality of life? So a couple of pieces that we're doing here locally and nationally, I know it's a push too, is we're providing survivorship care plans to our patients, And what that is it's a summary of the treatment they've had, and then it's a summary of what their 5-year follow-up's going to look like. So then we meet with the patient, go over that with them, let them ask any questions. It also details any other cancer screenings that they need to participate in, whether related to theirs or not. And then a copy is provided to their primary care physician too. And that helps with the continuity of care as they transition back to their primary care for the majority of their healthcare needs from their oncologist. And so we're trying to improve communication between primary care and the patient and just provide better quality of life, catch any side effects or symptoms they're still experiencing.
Oh, gosh.
So then the other piece that we're really excited about is we just finished a 6-week class for our survivors. And it was a series covering everything from late physical side effects to cognitive issues, stress, emotion, reintegrating back into the workforce and finding meaning after, life after cancer treatment. So it's really, really exciting what's coming down.
Oh, that is awesome. What a great coordination of care for the patients.
Yeah.
So quickly, I just want to ask one more question. Do you as nurse navigators get involved in the prevention part of cancer?
Yes.
Can you tell us just real quickly about
Sure.
that?
And Pam and I are involved with anything from county committees to statewide events, Relay for Life, Race for the Cure, all that kind of thing. One of the big pushes is the colorectal screening right now, to have 80% of eligible patients screened by the year 2018. So that means patients age 50 to 75 should be current on their colorectal screening unless you have any symptoms such as rectal bleeding, that type of thing, then you should be worked up early or a family history.
Thank you, Emily. We'll see you next week on Healthy Living for Life.
Healthy Living for Life is brought to you by Mountain Pacific Quality Health. We'd love to hear from you. If you have suggestions for future programs, visit our website at mpqhf.org or call us at 406-443-4020. You can also catch us on YouTube by visiting our website and clicking on the YouTube icon. Special thanks to Fire Tower Coffee House and Roasters. Production facilities provided by Video Express Productions.